Thank you, Richard, for keeping us straight. So good afternoon and welcome to today's bill hearings for the House Health and Government Operations Committee. This is a virtual committee meeting, so I ask for your patience if we encounter any technological or streaming issues. My name is Jocelyn Peña-Melnick. This bill hearing is being streamed on the Maryland General Assembly YouTube channel. Remember that even though we're meeting on Zoom, please adhere to our usual committee rules of one question and one answer from the panel. Not one question and one answer from each individual panelist. Also, please keep your questions shorter than the expected answer. The bill sponsor or a designee is allotted 5 minutes to present the bill. 5 witnesses will each be allowed to speak for 2 minutes in support, and Richard keeps great timing. Please stay in the hearing until the delegates have had an opportunity to ask questions. If they want to, next 5 witnesses will each be allowed to speak for 2 minutes in opposition and then respond to questions. Please conclude your remarks when you see the timer, please. It's important because we have other witnesses and members. Please, you must remain present with your video camera on during the entirety of the hearing. We really appreciate that. Today's bill hearing schedule is as follows and in the following order: House Bill 213, followed by 287, followed by 297, and we will conclude with House Bill 293, which is actually jointly assigned with Delegates Young, Valentino Smith, and Maggioni, and the staff, Chung. So welcome to the Health and Government Operations Committee. Delegate Kelly, House Bill 213, title Health Information Exchanges, Definition and Privacy Regulations. Good afternoon, Delegate Kelly.
Thank you so much, Madam Chairman. I am here today with David Sharp, and I'm going to save most of my time for him because this is a pretty technical bill. But just for background for the committee, you will remember that last year we passed House Bill 1375, which strengthened the privacy protections surrounding health information exchanges by providing a one-stop opt-out website for Marylanders to opt out once they have their privacy instruction. For all 11 health information exchanges in the state. So we did that bill last year. One of the components of that bill, though, was to align the definition of health information exchange with a new federal definition. As we were discussing that part of the bill, it became clear that we needed some more time with the stakeholders to find consensus around what that definition should look like. So we took that part out of the bill last year when we passed it, and we decided to come back again this year. We spent the interim working with stakeholders on that definition. And David is here today to talk about that progress, which is what the bill is before you. I will say that you should see in your file some information also from the AG's office and some consumer groups who have raised some further concerns and need some clarification around some of the language. So we are working with them on an amendment as well. With that, I will pass it off to David to explain further.
Good afternoon, David. Mr. Sharp.
Good afternoon, Chair Peña-Melnick, Delegate Kelly. Well put. Members of the committee, good afternoon. For the record, my name is David Sharp. I am the Director for the Center of Health Information Technology and Innovative Care Delivery at the Maryland Healthcare Commission. I'm here today in support of House Bill 213, Health Information Exchanges, Definition and Privacy Regulations. The bill is a follow-up bill to House Bill 1375, Health Information Exchanges, Electronic Health Information Sharing and Disclosure, that passed during the 2021 session. The bill included language to align the definition of a health information exchange, or HIE, in statute with the federal definition of an HIE, and for the state-designated health information exchange, CRISP, to develop and maintain a consent management utility, which allows consumers to opt out of having their electronic health information shared by an HIE. The revised definition was taken out of the bill due to concerns payers had with the definition. The MHCC worked with payers during the summer to make changes to address their concerns. Absent changing the definition of an HIE, consumers choosing to opt out of sharing their electronic health information may need to complete separate request forms for up to 11 different HIEs operating in Maryland. Aligning the definition of an HIE with the federal definition requires HIEs to use standards that support interoperability. Several stakeholders have suggested further clarifying that the intent of the bill is to broaden the definition of HIE to ensure a consumer consent management utility is broadly available. We look forward to working with stakeholders interested in this legislation. We hope this information is helpful and encourage a favorable report on House Bill 213. Thank you, Chair Pena-Melnick, for the opportunity to testify.
Thank you for being with us today. Are there any questions from our members? And I will look, if you will please raise your hand, and I'll look at the participant panel, see if there are any questions. I see Delegate Bonnie Collison. Delegate Collison.
Thank you very much, Madam Chair.
My pleasure.
Hi, David.
Hello.
Thank you. So let me, I want to make sure that I'm clear on what this means. What I think I heard you say, that under this bill, if I wanted to opt out my information, the sharing of my information, I would only have to do it once, and any HIE that I was affiliated with, it would immediately translate to those. Is that true?
Excellent question. Thank you, Delegate Collison. So the short answer is yes. Last year, the work that of this body and the General Assembly that passed legislation required CRISP to implement a consent management utility enables consumers to opt out of a centralized location, and that information is shared across all HIEs. And they can also choose to opt back into information sharing at a later date and time of their choosing.
May I follow up, Madam Chair?
Yes.
And that centralized location is, where do I get that information about the centralized location?
So we call it it's called the consent management utility, is actually under development currently by CRISP. We are working with the HIEs in the state to complete the technical specification, design, and implementation. We will educate consumers through lots of different avenues, as well as providers, on how to share that information with consumers once the technical specifications are fully developed, and we've had a chance to test with all the 11 HIEs in Maryland.
That's very, very helpful. Thank you very much, David.
You bet.
Are there any other questions? Delegate Hill.
Yes, thank you very much. And thank you for this bill. I just want to be clear, David. This gives a better definition to comply with federal requirements for CRISP. What other entities might be now captured under HIE that weren't before? For instance, we're all getting tested at various pharmacies and vaccinated at different places. Are they now captured too? Are they accepted, or how does that affect other things besides CRISP?
Great question. Thank you, Dr. Hill. So essentially today, what we align by aligning the definition to the federal definition, which says an HIE, it means, and then it gives the elements that are in the bill. Think of it this way: your electronic health record vendor in your office, Cerner, Epic, SureScripts, Allscripts, Greenway, to name a few, the larger ones, Meditech, they have an HIE component in their solution, in that technology that functions the same way CRISP does. So it's for any provider whose system has an HIE utility to it, they are required to comply with the bill. And we've default back to the definition by ONC because it's a national definition that covers not only HIEs, but developers of software products that have them certified that include modules for HIE. So it's a little complicated, but think of it as a utility to your electronic health record system.
All right, thank you.
You bet.
Delegate Bandari.
Thank you, Madam Chair. David, how is this bill, when it will be enacted, is capable of connecting diverse stakeholders?
Delegate Bandari, you broke up at the end of
I'm
the
so
question.
sorry. Thank you. So like when we align this, as you mentioned, that House Bill 213 aligns the definition of health information exchange, right, in statute with the federal definition, right? And so how this bill is capable of connecting diverse stakeholders?
I see. So good question. So what happens is it requires the vendors that utilize that are in the offices of providers, ambulatory providers, hospitals, could be a nursing home, anyone who uses any provider of care that uses an electronic health record system to meet the requirements of the specifications for CRISP and to check the CRISP solution every time there's a call to exchange the patient's information. So if the consumer opts out, that opt-out message carries throughout the entire system. So if you visit your ambulatory provider over here and you've opted out and then choose to see your specialist over here, that message of opting out would go to those providers and they would be essentially told that Delegate Bandari has opted out of information sharing. And the provider would then choose to either follow up with you and say, hey, look, is it possible for me to figure out to have access to your information? In which case you may say no. But it would alert the provider, the treating provider, that you as the consumer have chosen not to share your information at all endpoints. Does that help, or is it too?
Yeah, no, thank you for the clarification. Yeah, we can follow up offline. Thank you.
Sure, happy to do so.
Any other questions for Mr. Sharp? Seeing none, thank you so much, David, for coming to us and for your testimony and always for helping us.
Thank you.
The chairman and I appreciate it. So this actually concludes the bill hearing on House Bill 213. Next, we have House Bill 287, which is Delegate Peña-Melnick, myself, and the title of the bill is Secretary of Health Professional Qualifications Requirement. So good afternoon, Chairman Pendergrass and members of the Health and Government Operations Committee. I'm pleased to present to you House Bill 287, titled Secretary of Health Professional Qualifications Requirement. This legislation will require that the Maryland Secretary of Health be professionally qualified through experience or education in at least one of the following areas: health law or policy, healthcare facilities administration, like a nursing home, hospital, assisted living facility, where they actually oversee the finances, the staffing, and they also are familiar with the standard of care, health economics or financial management, government operations related to healthcare or healthcare delivery, also as a healthcare provider. That is what the bill requires, very simple. The Secretary of Health is a position of critical importance, especially given that we are now in the third year of living with COVID. We don't know what the future holds. Our public health care system has been underfunded for decades. It needs a lot of work. House Bill 287 will align Maryland with more than 20 other states that have enacted similar requirements. These include California, New York, Pennsylvania, Virginia, West Virginia, and Florida, among many other states. The diversity of this list, which includes red, blue, and swing states, both rural and densely populated, reflects the common sense nature of this legislation. This legislation is not directed at any specific administration or individual. It applies only to future appointed Secretary of Health in the state of Maryland. It does not take away the governor's right by law to appoint. It simply aligns Maryland with many other neighboring states. And I thank you for allowing me to present to you House Bill 287, and I respectfully request that you give it a favorable vote. Thank you so much. We also have a unfavorable, which is Mr. Vince McCulby. Is he in, Richard?
No, ma'am, he is not.
Okay. Are there any other questions? Are there any questions for House Bill 287? Delegate Saab.
Thank you, Madam Chairman. And thank you for this bill. Just have a quick question. Do we require this to any other secretary cabinets in our state, or even the states that actually allow this? Do they also dictate what other cabinet members qualify to hold an office?
In other states, some do. I'm not familiar whether we require it for some. I know for some we do, but we can get that offline for you.
Thank you. I appreciate it.
My pleasure. Delegate Rosenberg.
Yes, thank you, Madam Chair. If my memory serves me correctly, didn't we used to require that the Secretary of Health be a doctor? So that in effect, this is broader, a broader set of requirements and broader in scope than what was the law, if in fact that was once the case.
Yeah, I am not familiar whether it was once the case, but it is broader. It does not require that it be a doctor. It's actually much broader. That is correct.
Thank you.
Delegate Chisholm, followed by Delegate Morgan.
Thank you, Madam Chair. I actually like this bill. When you looked at the other states and their requirements, does this bill kind of mirror what the other states do? And then who ensures that they actually meet the requirements?
This actually does mirror a lot of the other states. Some do require them to be a medical doctor, but some actually require what we do. And the person that would make sure will be the governor, as he or she is vetting that individual. I would assume that they would ask for their resume, and they will make sure that they have the qualification before they put it forward to the Senate. They will have to actually approve the governor's decision.
Okay, thank you, Madam Chair.
My pleasure, Delegate. Thank you for your question. Delegate Morgan.
Thank you, Madam Chair. I'm looking at the fiscal note. It says this bill takes effect July 1st. So I was just wondering from a practical standpoint, how would it affect the current secretary?
It wouldn't affect the current secretary because the current secretary term ends in December, if I'm not mistaken, so it wouldn't.
Okay, okay, gotcha. I understand it now. Thank you.
My pleasure, Delegate Morgan. Thank you for your question. I don't see any other questions. And actually the other unfavorable witness is not here. So this members of the committee concludes the bill hearing on House Bill 287. We will now move on to House Bill 293, Delegate Young. The title is Behavioral Health Crisis Response Services, 988 Trust Fund. Delegate Young, will you be so kind and get started?
I'm happy to do that, but I got an email that we switched the order and that my bill's now.
Actually, you know what? That is very true. I apologize for that, but I know you're always ready. So
I just want to make sure my panel is.
You're right. We're giving actually time for our appropriation members to come, a courtesy to them, because they will be sitting in on your bill hearing. So Delegate Rosenberg, House Bill 297, Facilities, Disabilities, Juveniles, Behavioral Health, and Healthcare Safety Plans. Delegate Rosenberg, you're on. Good afternoon.
Thank you, Madam Chair.
My pleasure.
This bill builds upon legislation that we passed last year, Senate Bill 96, which provided that behavioral health facilities in the community had to have a safety plan for the safety of all of the individuals living in that facility and working there. This bill would extend that principle to facilities of juvenile services, as well as for persons with disabilities under DDA. This is appropriate. We felt last year, and I would hope the committee would concur in broadening the scope of that of that requirement. It is consistent, we believe, with the Fair Housing Act, and I have an AG's letter that I will make available to the committee. Also, we didn't have it ready 48 hours in advance, but have a statement from 5 community leaders in our district, in the 41st district, in support of this legislation that I will also make available to the community. And we also want to make an issue was brought to our attention by one of the advocacy groups, that requiring that this statement be updated every 5 years would be better put as within every 5 years, because there is already a requirement that it be done within a 3-year period. So this is a safety plan on its own benefits. The people who live and work in these facilities, as evidenced by the judgment that we expressed last year in passing Senator McCrae's bill. And this bill would extend that same principle to other similar facilities, juvenile services and developmental disabilities. So I would urge a favorable report. Thank you.
Thank you. Our next witness, Ms. Jennifer Sutton, is not here. I understand that she's not here, so we're going to go on to Ms. Lauren Kalins from the Maryland Association of Community Services. Are you here?
I am. Are you able to hear me okay?
Yes, we can hear you and we can see you. Good afternoon.
Good afternoon. Thank you, Madam Chair and members of the committee. Thank you for the opportunity to speak today. I am Lauren Callens. I'm with the Maryland Association of Community Services, and we represent community providers across the state who provide services to people with intellectual and developmental disabilities. We are here today in support with an amendment, and this is an amendment that tracks language that was added to Senator McCrae's bill last year. Health and safety is at the core of the mission of our members who provide services that enable people with IDD to live inclusive lives in the community. And our members are heavily regulated under COMAR with regard to health and safety. Safety plan, every person's individual plan must have a very detailed description of their health and safety needs. And COMAR is very specific, and I put the reference in our testimony regarding emergency and disaster planning. So, and that is part of the regular licensing process. And so the language we asked for last year, and I have spoken to Delegate Rosenberg this year about similar language, would reflect that a safety or an emergency plan that had been created for another purpose might satisfy the requirements under this subtitle. So we are again seeking that language and urge your favorable report and adopt the language. Thank you.
Thank you for being with us today. Ms. Jennifer Sutton, I don't see her. We're going to go on to questions. Are there any questions for Delegate Rosenberg regarding House Bill 297? 1 second. I don't see any, although let me go all the way to the bottom. There's none. Thank you so much for your testimony today. This concludes the bill hearing on House Bill 297. Now we're on to the last bill of the day, which is House Bill 293, and that is Delegate Young. And we are supposed to be with our appropriations members. Have they made it?
Yes, ma'am.
Okay, wonderful. So now we're going on to House Bill 293, Delegate Young, Behavioral Health Crisis Response Services, 988 Trust Fund. Delegate Young, will you be so kind and get started?
Thank you. I might mention that not all of my panel members have received the link. So Richard, could you check that while we get started? Thanks
Absolutely.
so much. And good afternoon, colleagues. Thank you so much for giving me the opportunity to present this bill to you this afternoon. By the very nature of sitting on this committee, you're all aware that we had a mental health crisis prior to the pandemic. Last spring, I became acutely aware that we also have a mental health pandemic that is equal to, if not greater than, the coronavirus pandemic, but it will last longer. And so as part of my activities in attempting to address that challenge, I reached out to the local executive director of the Mental Health Association, and I said, what can I do to help support your efforts? And she said, well, one thing you can do is help to obtain funding for 988. 988 is the National Suicide Designation. It was passed in 2020, and it establishes 988 as a universal number for mental health crisis and suicide prevention. In July of this year, it's going to go live. Beginning then, all phone companies will route 988 calls to local crisis centers that are part of the Lifeline network. The local crisis call centers provide 24/7 free confidential emotional support to all individuals calling for help. It's expected that these calls are going to increase by as much as 30%, but this federal mandate did not come along with funding. So the states were challenged to come up with our own methodology. And that's what this bill is about. We looked at other states. Many of them were adding on telecommunications surcharges. We did not want to do that. So this establishes a 988 trust fund for the purpose of providing reimbursement for costs associated with designating and maintaining 988 as a universal telephone number for national suicide prevention and mental health crisis hotline, and developing and implementing a statewide initiative for the coordination and delivery of the continuum of behavioral health crisis response to the state. I have with me Daniel Babbitt, who I'd like to donate the rest of my time to, who will give you the details of how we will implement it. And we'll also be hearing from the Chief of Police from Frederick City, who will tell you how this will assist law enforcement in their efforts. Thank you.
Thank you. Mr. Dan Rabbitt, will you please get started?
Thank you, Madam Vice Chair. Madam Chair, members of the committee. For the record, my name is Dan Rabbitt, Policy Director at Behavioral Health System Baltimore. BHSB is the local behavioral health authority for Baltimore City and a strong supporter of behavioral health and suicide crisis response and HB 293. I am also testifying today as a representative of the Fund Maryland 988 campaign, which is a statewide effort made up of 65 organizations and counting committed to investments in crisis services and a successful launch of 988 in Maryland. You can see in your packet over 50 letters of support from members of the campaign, showing the broad support this has across the state. The launch of 988 this year represents a once-in-a-generation opportunity to strengthen our behavioral health system and reimagine how we respond to those experiencing a behavioral health crisis. Congress took the first step by passing the Suicide Hotline Designation Act, which started this all in motion, but now it's up to states to take the next necessary steps to make our system more robust and dependable. 988 is building upon the network of local crisis call centers that we already have today in Maryland. There are 8 accredited crisis call centers that already participate in the National Suicide Prevention Lifeline Network, and those 8 call centers are expected to be to remain the backbone of the network for 988. What HB 293 does is it helps Maryland take that next step to ensure we're ready when a 988 launches. It establishes a Maryland 988 trust fund, and it deposits an initial $10 million to support 988 implementation. This figure is based on a SAMHSA funded estimate of what Maryland needed to ensure its call center network can handle the expected increase in volume. What we've seen in Baltimore City is that our Here to Help hotline which is part of the network, has had its call volume double since the start of the pandemic and has not gone back down at all. We're the sole funder of that hotline, and we know that we funded at $1.8 million. And that hasn't changed to acknowledge the doubling of call volume. And we know that we're going to need at least that much moving forward. $10 million is a minimum, not a maximum, of what the state needs to launch 988 successfully and prepare for the increase in call volume. If we don't make these investments, Marylanders in distress will continue to fall through the cracks. Every year, hundreds of thousands of people go to the emergency room or call 911 when they are overwhelmed and don't know where to turn. In Baltimore, we saw 13,000 calls for behavioral health reasons go to our 911 system. These systems, though, are not designed to serve people experiencing a behavioral health or suicidal crisis. Emergency rooms are chaotic, and those with mental health needs often wait hours or days while hospital staff triage other medical emergencies. Law enforcement dispatch are trained to protect public safety, not to provide mental health services. These settings and interventions can sometimes even do more harm than good. They're not an efficient or effective use of our state's resources. People experiencing behavioral health or suicidal crisis deserve support that is tailored to their needs. Investing in 988 and our local call centers through HB 293 will help build this system that they need to be safe and well. We ask a favorable report.
Thank you so much, and your timing was perfect.
Right?
Yes, it was. Next, we have Chief Jason Lando. Good afternoon, sir.
Good afternoon. Again, my name is Jason Lando. I'm the police chief for the city of Frederick, and I'm here today in support of House Bill 293. Every day across the state of Maryland and across the United States, law enforcement responds to 911 calls for individuals who are suffering from mental health emergencies. Police officers respond to these emergencies, and they do their absolute best to manage situations in the field that are really best dealt with using trained mental health professionals. While it is true that at times police are needed for volatile situations, most of the time these calls do not require police intervention. Often the only reason people dial 911 is because they don't know who else to call when someone is suffering a mental health crisis. This often places police officers, as well as those in crisis, in situations that do not end well. As mental health concerns increase year after year, we need a better solution than to always rely on the 911 system and the resources of police, fire, and EMS agencies. Establishing 988 as the statewide mental health emergency number will provide an alternative option for individuals who need emergency stabilization, but do not require police or EMS response. Establishing and promoting 988 as the statewide number for these types of emergencies will not only allow for better outcomes for those in need, but will also reduce the strain on our public safety resources. Thank you for your time.
Thank you for your time today. We appreciate you, and thank you for your service.
Thank you.
Next, we have Denise Camp. Did she make it, Richard?
Yes,
okay.
I'm here. Thank you very much.
Our pleasure. Welcome.
Thank you, Delegate Pendergrass, Vice Chair Pena-Melnick, and committee members for this opportunity to speak. My name is Denise Camp, and I represent On Our Own of Maryland, a peer-run advocacy and education organization serving over 6,000 behavioral health consumers across the state. So in the time I have, please let me share a story of a person in our network who had a behavioral health crisis that ended in trauma, hospitalization, unexpected expenses that could have been avoided if 988 had been an option. The person was in a public setting. Their loud speaking and yelling indicated to bystanders that they were not well, but they were not a danger to themselves or others. There was no aggressive behavior or weapon. The receptionist at the location called 911. The police arrived, they handcuffed the individual, threw them to the ground, and put them on a stretcher to go to the hospital, resulting in humiliation and trauma, unnecessary forced treatment, unplanned medical bills, and unnecessary expenditure of resources for the situation. If calling 988 had been an option, the person could have spoken to trained staff with the ability to find them timely outpatient services or deploy a mobile response team for on-site support. And Though it wasn't true in this particular case, people often do not get connection to community-based recovery services. If 988 had been available as an option, the response would have been a mobile response team of trained clinicians and peers, or perhaps crisis intervention team police officers who have specialized training in behavioral health, crisis de-escalation. Crisis response is a safety net for people like me who, when they are in a debilitating state of mind. So On Our Own of Maryland strongly urges your support of House Bill 293's critical investment in our crisis response system and 988 to make sure all Marylanders receive quality, effective, respectful, and safe real-time support when seeking help in their most vulnerable and difficult times. Thank you so much, and I apologize for going over time.
It's okay. And thank you for the work you do. We really appreciate you. So next we have Mr. Bob Linton.
Hi, can you hear me?
Yes, we can, and we can see you. Good afternoon. Will you please get started?
Yes, good afternoon. My name is Dr. Robert Linton II, and I'm a practicing emergency physician, the medical director of the emergency department at Howard County General, and the current president of the American College of Emergency Physicians Maryland chapter. I'd like to thank you for the opportunity to spend a minute expressing support for HB 293. I've been an emergency physician for nearly 23 years practicing in the state, and I've seen firsthand the impact of the mental health crisis on our emergency departments. The last 2 years in particular have deepened the need for better access to community mental health services. The transition to 988 as the National Suicide Prevention and Behavioral Health Crisis Hotline represents a great opportunity to strengthen our behavioral health system in Maryland. A brief example I'll give is a patient that I took care of just this past Monday. He was seeking behavioral health services for what he felt was a crisis, and he needed help. He called 911 and he was brought to the emergency department by police. He was promptly evaluated by an emergency physician, but there were several patients ahead of him who had more severe illness, and it took over 12 hours to get a safe disposition for this patient. Potentially 988 could have been an option for this patient, right? This would have allowed him to potentially receive more prompt care in a more appropriate setting. So make no mistake, we take great pride in being considered the safety net for the community. And there are certain patients with behavioral health illness who absolutely need to be in the emergency department for stabilization. We do, however, feel that investing in 988 as the state suicide prevention and health crisis hotline will improve the system and ensure people in crisis get the help they need in the right place at the right time. For these reasons, we urge a favorable report.
Thank you, Dr. Linton, for your service and for making time today. I know you're busy. We have the last witness for this bill is Ms. Shannon Alexis. Good afternoon, ma'am. Will you be so kind and get started?
Thank you. Good afternoon. My name is Shannon Alexis. I'm the CEO of the Mental Health Association of Frederick County. We operate the call center that serves Western Maryland and we have been doing so since 1985. We answer 7 incoming lines, including the National Suicide Prevention Lifeline, which you know will transition to 3-digit dialing later this year. We also answer 211, including 211 press 1 calls. Maryland currently has 8 centers who are answering these 988 calls. Last year, the centers answered over 30,000 calls, and projections are that the number of calls will increase significantly after the transition to 3-digit dialing. Maryland's strength is that we have a strong infrastructure of existing call centers that have answered this line from its inception. And we have well-trained staff who are able to resolve 90% of situations without involving other interventions like 911, police, or the emergency department. Our staff talk openly about suicide and help callers formulate individualized safety plans. We offer follow-up calls and are available whenever we are needed. Unfortunately, we are not adequately funded to provide this critical life-saving service. The current funding we receive to answer National Suicide Prevention Lifeline is less than $700 a month to be available 24/7, provide staff who are trained to assist callers who are thinking about suicide or who have maybe made an attempt prior to calling for help. The centers believe this is a critical service, and that's why for years we have cobbled together any funding we can to support this work. But the transition to 3-digit dialing means we can no longer operate in the same way. Maryland's state crisis line was established in 1990 and was a model for the original National Suicide Lifeline. We have the opportunity to continue to model effective crisis hotline work. Your support of this bill will help support the call centers, which are the foundation of the crisis system Maryland is working to build. Thank you very much.
Thank you for being with us today and for the work you do. Members, we have been joined by the Appropriations Committee Delegates Young, Valentino Smith, and Mangione, which are welcome to ask questions as well. So are there any questions on House Bill 293? I'm looking. Delegate Krebs.
Thank you, Madam Chair. And
My
thank you to
pleasure.
those of you who called me. We had a meeting on this earlier, I guess last week, and let me ask a lot of questions then. So I'm going to limit my question to currently, this is for the subcommittee to food for thought. We currently have a Maryland Health Crisis Hotline, which is 211. And I want to ensure that what we already have in place, how this is going to go together with that. There's already funding for some pieces, components of 211. So, you know, my question just for the record is, how will this complement, or how will we work with marrying what we already have in place in our locals? And it's all written in the fiscal note under what we're already doing with 211. And now we have the National 988. So how will we coordinate these two, coordinate efforts, and make this do what we expect it to do?
That's a great question, Delegate Krebs, and thank you for bringing it up. So who's the best person, Delegate Young, to answer this?
I believe Daniel is.
Thank you.
Sure.
Mr. Rabbit?
Yeah, happy to take the question, and thank you
Thank
for
you.
the question, Delegate Krebs. It's an important one. You know, Maryland has done really great work in building out the 211 Press 1 system, and Maryland was kind of like ahead of the game in doing so. And so Maryland has a system today that will route calls through 211 Press 1 to the local call center. And in almost all the cases, the local call center you get routed to when calling 211 Press 1 versus the local call center you get routed to through the National Suicide Prevention and Crisis Hotline is the same call center. It's the same people answering the call. It's just a different route, a different routing system that gets you to that call center. What 988 will do, you know, so we think in the near term, the good work that 211 Press 1 has done and the promotional activities that have gone on around 211 Press 1, you know, will serve Maryland well. So if someone is in crisis and they remember 211 Press 1, they can call that and get connected to their local call center. If they saw a 988 commercial and they think of that, they can call 988 and get routed to the same call center. We think over the long term, since SAMHSA and Congress and all the other states in the country are moving towards 988 as the behavioral health and suicidal crisis hotline, that we think Maryland should align our efforts with those efforts. And so this bill, you know, our vision for all of this is for the state to work with the federal government to promote 988 and to align our efforts in that way. But 211 Press 1 can continue to be an access point for people to get connected to the services that they need.
Thank you. I'll ask my other questions offline. Thank you.
Okay,
Sure.
Thank you, Delegate Krebs. Delegate Collison.
Thank you, Dan, for that explanation. And I certainly hope that we will continue to support 211 Press 1. My question is, just to clarify, I think this is what I heard, just want to make sure that I heard it. If a person dials 988, they are going to be directed to someone inside Maryland, right? It's not going outside the state.
Yes. As long as the local call center answers the call within 30 seconds, I believe it is, then they will be connected to the local Maryland call center. If it goes longer than 30 seconds, which is what may happen if call volume exceeds staffing capacity, then it's kicked to a backup system. And there's different centers around the country that operate as a backup when the call isn't answered in time.
Okay, great. Thank you. That's helpful.
Any other questions from the committee? Let me just check, make sure I don't miss anyone. I don't see any. Thank you so much for being with us today. This will conclude the bill hearing on House Bill 293. For the members, we do have a 4 o'clock briefing on the Behavioral Health Administration on Upton, and it will be the Health and Government Operations Committee jointly with the Appropriations Committee at 4 o'clock. Thank you so much for being with us today. Have a great afternoon.